corneal haze and shallow AC. The worst scenario that you can have is a big arcus, bad cornea, one-eyed patient, extremely shallow anterior chamber, huge pregnant cataract which is almost going to the retina, anterior chamber which is flattened at the periphery. You don't really know how to enter and what is the way to go about with it. Well, thanks for your time, for being here for this important session and sparing your valuable time with us. Of course, at any given point of time, all of us know that knowledge shared is knowledge doubled, and a geometric progression, not an arithmetic progression. Describes a condition called a cloudy or opaque appearance of the cornea. As you can see, this could be before starting, Reese-Buckler atrophy, Foster-Fuchs. You have various kinds of corneal problems and haze which can come, a corneal opacity, nebulomacular to a leukomatous opacity, obstructing your view while doing your surgery. How to go about with it, how to use chandelier illumination, how to go about with, there was a time when we used to work without any trypan blue staining, and it should be very difficult. So let's divide the preoperative haze scenarios and the intraoperative and the postoperative haze. When we talk of corneal haze, the only thing as surgeons we are guilty about is, everybody loves to say after any complex surgery, cornea was clear and vision was 6-9 next day. We all love saying that. But said easily, only the surgeon knows how much of heartbeats. We generally tell the patient, nahi, kuch nahi, acha ho jayega. And the patient, any cataract patient, however dirty it is, a dirty brown cataract, bad endothelial cell count of 1100, bad cornea, shallow AC, huge cataract. But the patient only knows one thing, baju wale ke to acha ho gaya. And they are not really bothered that how much struggle that you are going through. How to deal with that situation. Classically I have this patient, a brown cataract you operated, dirty brown 85-year-old lady, you operate, had struggled a lot to operate, took some time, really struggled, sweated it out, increased your coronaries, and you did a great job. But the next day the patient says, lekin kal to main paper pad sakti thi, abhi nahi pad sakti hu. You know how frustrating it is? Yeah, everybody's nodding, so we've all gone through it. If I've gone through it, you've also gone through it. And it's amazing to tell them, what the hell do I tell you and what have I done for you? We have underrated ourselves to a great extent in our life, unfortunately. वो 5 मिनट में cataract हो जाता है, कोई problem नहीं है, और घर पे जा सकते हैं, कल ऑफिस में जाएंगे. So preoperative haze preparation, most important. Specular and topography. I've learned gradually in life that every patient of cataract, you must do a specular, you must have an endothelial cell count in your hand for your own sake and for the medical legal standpoint. Your sake because you might use lovely technique, sandwich technique, whatever that you want to use, we'll discuss that further. But for your sake, you must know which cornea that you are going in. Even for the army goes into Kargil or whichever area, even Zelensky survived because he had satellite images. He knows what was coming from where. So if you don't know your topography of what's happening to the patient, you will land up into trouble. You will not take the right precautions. And the cornea may be relatively very simple. You won't even know. It'll hit you. And the patient doesn't understand. In a medical legal case that I have seen in 2 cases that I've been called for, have been where the endothelial cell count to begin with was a very bad endothelial cell count. So don't economize for the patient's sake. We generally have this thing, ke paisa ho jayega, kharcha ho jayega. Don't worry about that. They are not going to leave you if you try to save their money. Anterior segment OCT to give you the exact findings of what's happening. Adjusting the illumination and the angle of incidence. That can definitely help you. Intraoperative haze can be in the form of air bubbles, drying of the epithelium of cornea, excess staining with dye, and an intumescent cataract. Postoperative, of course, corneal edema due to high phaco time, mechanical damage to endothelium, Descemet's detachment, high intraocular pressure. This is something which every surgeon is scared about. What is a surgeon, an ophthalmic surgeon, really scared of? 2 things, the corneal endothelium and the posterior capsule. These are 2 dangerous enemies. We try to save at any given point of time these 2 things that we can control and we should be able to control. Sorry? Yeah. CME is post-op, but intraoperative, that I'm really worried. I mean, we are always scared of the worst day is first post-op day. You never know what is in store for you. You done a clean-cut cataract, but your cornea may be hazy. You can have any problem in life. That's why the surgeons are always on their toes every given point of time. So we'll discuss each one of them. preventing the haze is a very important criteria. You have excellent viscoelastics available, dispersive and cohesive. Use them at your discretion. Now you have the Indian versions also. Fairly good, relatively very cheap, don't economize. If you are doing a Rexis in a highly positive pressure, a hypermetropic patient with a 20.5 or a 21 kind of axial length, extremely shallow AC of 1.8 or something, it always helps that you use a good dispersive, use your mannitol freely. It shouldn't create a problem for you. I have in some small eyes of 19, I have also done a small vitrectomy to reduce the pressure. The first step is that you should have a fairly decent entry. I'm going to show a video where I goofed up and what was the message that I wanted to learn from that. We'll come to that. So use this viscoelastic freely, don't hesitate, don't worry about anything else. End of the day, results matter, don't worry about the cost. And the DuoVisc or whichever kind of cohesive your chondroitin sulfate with sodium hyaluronate available freely from Indian companies, use them, they are good. I haven't had any problems, I've used them. This is just to tell you the Viscode OVD and the ProVisc which is available in the market. You don't have to buy, these names have no meaning to me. What we are trying to tell you is sodium hyaluronate 1% or 3% hyaluronate with 4% chondroitin sulfate. That's the one which gives you really good depth. It doesn't walk out with you if you're doing a Rexis. Of course, in wound architecture, in a case like this, Rohit will explain the importance of what is so important, how well to protect your iris and your structures inside. So the soft shell technique is one of the most easily described and the best technique that works very well. Use your dispersive so that your endothelium is protective. Use the cohesive. Try and work with low fluidics relatively. Don't have too much of fluid coming out of the eye. Work in the bag area and try and get on with your nucleus in whichever technique that you are comfortable with. Here is a case which I want you to see. Here was a case which was classically, as I described, extreme high pressure, very small eye, shallow anterior chamber, and what is it that we started doing? I'm taking the incision. As you see, as I'm starting to put in, look at that, it's coming out. As you saw that is coming out, there is not much place for any viscous or dispersive viscoelastic to get into the eye. Now you know that you start your mannitol at this point in time if you wish to. Reduce the vitreous pressure as much as you have. Loosen your speculum. Easiest thing is to loosen your speculum. Reduce the pressure on the eye because quite a few of these eyes are deep socket, shallow chamber, small eyes, and to get access, we increase the speculum, we open up the speculum. So do that. Once your incision is there, sorry. Trying to take an incision, taking a deeper incision so that the iris does not prolapse. Important even for the side port, that you go through a little longer distance so that the iris doesn't walk out with you when the fluidics start. Sorry. Yeah, I know. So as the incision goes further, try to be a little further away. Hopefully that does not. Now look at that again. The moment I get in, the viscoelastic starts walking out again with me. Now I'm trying to get into the wound. Now I'm trying at multiple points of time. Now here is where I could get into trouble. I could pull the desmids with me. I could take the iris with me. The iris can walk out. Every time the viscoelastic walks out, I can get into trouble right here and now. Why am I showing you this? What goof-ups I made. I just want to show that how one should not be going in further with that. By the time I try to do my Rexis, if my iris has started going down, I would have trouble. See again, my movement was not very good. the chamber was flattening. Again, I'm trying to put in more viscoelastic. I'm trying to get in. Now look at that, 4 or 5 times even to get a good grasp because my wrist was not moving. Ultimately, we all realize that while operating, we have learned that it is not just the wrist movement, it's not just the finger movement, it is the wrist movement, it is my shoulder which helps me depending on the socket and the eye. These are things which I have to change my posture, position my chair to see that I get a little easier access, and because if the rexis runs off at any given point of time, I'm in even more deeper trouble. So I change my position, I change my wrist position, I change my finger position. I'm a left-handed surgeon, so my things might be ulta for you. I'm a rexis person, not a needle. Again, finding it difficult because there is not much access that I had. This is where if things can go haywire and my rexis runs away, I can be in trouble. So I'm going very, very slowly. And like a hero, I decided to do it under topical. As you can see, the eye is moving. I would have been better off had I given a pinky ball pressure with a retrobulbar or a peribulbar. I'm refilling the chamber again because if the chamber shallows, your rexis becomes smaller. And then you have even more trouble because the success of this surgery is only on the rexis. If you've got a big, good enough rexis, you will not tear it, you will have good access to your nucleus. And 80% of the success in such cases is from a good rexis. Take your time because that is, if you goof up somewhere, that's the place which will give you trouble till the end. Including phimosis in the end. Okay, look at the iris trying to come out from my wound. Already anticipating trouble because I go with the phaco, with the fluid right now, I might create more trouble. Now, as I put fluid, I'm not sure, there's a lot of, the whole bag is extremely, extremely tense. It's not moving, there are capsulocortical adhesions here. I can't put in more fluid because I'm worried that I might rupture the posterior capsule. There's not enough place for things to escape. The iris is, the wound is not very friendly for that. Well, fair enough, I managed to enter, and now I have to see that I don't keep coming out. Once I'm in, I'm in. I have to finish the show and get off only at that time. I haven't had a great amount of movement of the nucleus. I haven't had a good hydrodissection, but I had to start debulking. The message here was the first thing in a case like this is to debulk, debulk, debulk. Try and remove smaller pieces. You will suddenly get more place in the capsular bag to function. Okay. Some breathing space that you manage to get some space for the nucleus to move. Again, it's not a free movement. And as I said, if your rexis was smaller, you could get into trouble because you're not concentrating on your rexis margin. Trying to be at the level of the below the iris plane, not trying to get fluid too much into the anterior chamber. Moving the later part, I'm still with the phaco probe inside the eye. I don't want to come out, as I said, because the moment I come out, the viscoelastic will walk out, the iris will walk out. All possible techniques that you learn, stop and chop inside to whatever that you wish to do, but this is where you will have to keep moving, debulk, remove fragments, small pieces by pieces. You may not know the extent of the epinucleus also. So now comes an interesting phase where the epinucleus is stuck, you have capsulocortical adhesions, and you want to go ahead and remove it. Go ahead, what I do here is more of hydrodissection, subluxate the epinucleus into the anterior chamber if I can, or just out of the bag, and then catch it by the neck and go ahead with the next part. This was to show you my mistakes which I made, where you should be avoiding. How can we tackle smaller eyes with smaller anterior chamber, small axial length. Look at this case. Here I have, as I told you, if you can see very clearly, bad cornea, big arcus, huge cataract, small pupil, patient with prostate medications, so the iris is not going to be good with you, one-eyed. Tell me, what more trouble do you want in life? From a surgeon standpoint, look at the anterior chamber at the angle, it's closed. The whole thing is, look at the size of the anterior chamber. So, well, that's how it is. So, this is a case where I would say femto can help you, because if you have a rhexis good enough, you can go ahead and you have a nuclear plate which is broken and fragmented. It can make, look at on the side, if you can see the anterior chamber is just not there at the periphery. The iris is touching the cornea. There is hardly any place for you to work. So, go ahead and adjust, and as you do that, it will help you on a femto. Look at how big the cataract is. As I said, it's almost going to the retina. That's how big it is. And this is a one-eyed patient. Brown cataract. So a nightmare for any surgeon. But once you have a rhexis, you have a decent exposure to the nucleus. You have a fragmented nucleus, which when you go in becomes a lot more easier for you to eat it up. And you have a little more respect for the iris at that point in time. Now, if you have a corneal opacity, you can have a retro-illumination or a side illumination, which can help you to judge with a trypan blue staining of the anterior capsule. Look at the opacity, look at from the side chandelier that you can have. The important thing, again I repeat at any given point, for any opacity otherwise, for any good cataract surgery, is a great rhexis, no question about it. So this is where I wanted to show you where all I goofed up, what I could try and avoid, which are situations where we could do. Before I call upon Suven for his talk, any questions that you have on this? Pre-op, intra-op, post-op corneal haze. Yes, sir.
What I think is, you have very usefully done the case.
Ji, sir.
But pre-operatively, what I do is, one thing is a proper retinal photograph of the patient to be done pre-operatively. Even subtle ERMs can be detected and it should be noticed.
So second, third, fourth, fifth is opinion. Every patient that I do, every patient, I have an AS OCT, I have a posterior segment OCT, I have a fundus photograph, and I'll tell you one more step that I do, sir. How many of you with me agree that patients post-operatively come and tell you that mera ek aankh chota ho gaya hai? Very good. How many of them tell you that black circles have started seeing? So how many of them tell you that puffiness, bags, then wrinkles?
And if it's the wife, the husband complains.
Correct.
If it's the husband, the wife complains.
Yes.
इतने साल तो आप देखे ही नहीं।
करेक्ट नहीं ये तो इजी है सुवेन ये तो इजी है वो वाइफ हस्बैंड को ब्लेम करता है लेकिन यहाँ तो अपने को ब्लेम करता है आपकी सर्जरी के बाद ही हुआ ही है सो आई हैव स्टार्टेड टेकिंग फोटोग्राफ्स प्री ऑपरेटिव एंड नाउ व्हाट आई यूज्ड टू डू इज प्री ऑपरेटिव एंड देन दूसरा मैं क्या बोलता हूं उनको कि प्लीज रिमूव योर ओन कैमरा गिव मी योर कैमरा शो मी 1 year बैक पिक्चर ऑफ योर ओन पिक्चर फ्रॉम योर कैमरा बाद में समझता है हाँ but they make it very serious issue as if you have done everything for them. So I agree.
All comes after the vision is 6 by 6.
Yes, after the vision is 6.
If the vision is 6 by 9, वो तो बाकी सब That's on the looks.
Yes. Any other questions? You know, post-op haze, we all know that we are worried. So minimum phaco time that we must be having. So I'm ready whenever you are ready. So minimum phaco time that we can have as much as possible. Stay away from the cornea. Use dispersive, cohesive, viscoelastic. And Dr. Subira, welcome. Thank you for the show. Any comments, please welcome Dr. Neha. Thank you for coming in. Any points, please do mention anytime. We will discuss this even further because all that we are all talking is what affects all of us day in and day out. Nothing wrong. Absolutely, I'm for it. Sir. Any which way the AC remains stable for you is your best friend. So going in and coming out as less as possible. If you saw quite often I came out of my side port because it starts leaking after some time. And he has shown something beautiful.
Sir, sound to nahi?
The size of your side port and the incision which you make from the side should be coinciding. It shouldn't be bigger. Am I right? Rohit, please expand. You can't say it better than me. You are showing that now. Great. So this is something which is a very practical point. How iris, your magnetic iris doesn't keep coming out with you.
Another important thing is one can always use, if one is using a cystosome for creating an axis.
Yeah, that would be.
Yeah, and then one can always use till the time it gets things done. One can use a micro forceps to calibrate it, save the data. That can also, because we don't want any ingress of
Please use the mic.
injection of fluid to the.
They can't hear
You have
what
to-
you're saying.
Rohit is with the mask. He's a masked man.
I think we can always add a micro incision for creating a capsular axis. What I would have also done separately in this is that I would have, not done hydro dissection at all.
That is.
I would have just started, done sculpting, debulking, and then do cross-talking because the nucleus sclerosis was.
Cross chopping. That's another very good point. Yeah, I wanted to show this where I moved up. I wanted everybody to learn. Criticize me badly. This is where we all will learn. No, constructive criticism. I would love to.
So that could have.
Yes, appreciate.